Welcome to our Casa Columbia seminar. We're delighted to have Dr. Stephen Ross from NYU School of Medicine and Bellevue Hospital, and I'll attempt to provide a short narrative on his career to accompany our first slide, which lists his many important roles at both of those institutions. Dr. Ross received his bachelor's degree from the University of Pennsylvania. Thanks, Tim. Summa cum laude, and then completed medical school at UCLA, and then came to Columbia Presbyterian and the New York State Psychiatric Institute to complete his internship and psychiatry residency. He completed a 2-year fellowship in addiction psychiatry at Bellevue Hospital and in the NYU School of Medicine, where he subsequently joined the faculty, becoming Associate Professor of Psychiatry and Associate Professor of Child and Adolescent Psychiatry in 2012. He has served in various clinical and training leadership roles, most notably as the Director of the Division of Alcoholism and Drug Abuse at Bellevue, and at NYU he is the Director of Addiction Psychiatry and its fellowship program and the Center of Excellence on Addiction. Dr. Ross also directs, a National Institute of Health-funded Addictive Disorders Laboratory at Bellevue and is the Director of the NYU Psychedelic Research Group. Dr. Ross is an outstanding teacher, having won 10 teaching awards at NYU, where he is extensively involved in the training of medical students, psychiatry residents, and advanced fellows. He serves as a consultant or on committees of numerous organizations, including the New York State Department of Health and OASAS, Office of Alcoholism and Substance Abuse Services, as well as on the New York City Health and Hospitals Corporation Board. Dr. Ross has lectured extensively to national audiences and published widely in journal articles and book chapters on the topics of dual diagnosis and the therapeutic use of psychoactive substances, including ketamine for severely depressed patients presenting to the emergency room, buprenorphine to reduce cocaine abuse among opioid-addicted patients. Steve, we're delighted to have you.
Well, it's a real pleasure to be here. Thank you for the introduction, Sam. It's an honor to be here. I've known about CASA for many years, so it's really nice to finally be here. Today I'm going to talk about a recently completed phase 2 FDA trial, randomized controlled trial, using psilocybin-assisted psychotherapy to treat cancer-related psychological and existential distress. And this trial was recently finished, and I'm going to present the data. This is probably the second or third time that I presented the data. It took about a decade to complete this trial. It was very difficult given that psilocybin is a Schedule 1 drug. So I'm going to go over the history of the use of psychedelics to treat terminal cancer-related distress in the previous era and in the modern era. So disclosures, my research funding comes from NIDA, NYU Langone, and the Hefter Research Institute. In terms of the outline today, we're going to talk about where Americans die and contrast that with where they want to die. And there's a big discrepancy there. I'm going to define palliative care and in particular talk about the spiritual domain defined within palliative care. I'm going to review the phenomenology and prevalence of cancer-related psychological and existential distress and its links to adverse medical and psychiatric health outcomes. And then I'm going to review psilocybin and review its history, ethnobotany, definitions, the phenomenology of the experience, chemistry, review its neurobiology, and also review its addictive liability or ability to actually treat addictive syndromes, and we'll talk about that. And we'll take a look at the history of how it got placed in the Schedule 1 category of the highest addictive liability and see if that's the case or not. And then I'm going to review the historical literature using LSD-assisted psychotherapy to treat cancer-related distress and what we learned from that era, and then come into the modern era. So where do people want to die? Who wants to die in a hospital? Raise your hand. In like an ICU setting, right? It's never popular. There's always like the near-death people that they say that they want to die there. But nursing home, anyone want to die there? Who wants to die in a hospice? Who wants to die at home surrounded by family members? And so that's this construct of a good death, and that's sort of like where we all want to be. But unfortunately, in American medicine, this is where most people die. The human encounter with death in the United States has been assigned to medicine for a long time, but the problem is doctors are very poorly trained in how to help people have this good enough death. When I was a medical student and a resident of Columbia, I remember spending time on the oncology wards, and there was no construct of how do we stop chemotherapy and how do we help this person facilitate the dying process. We were trained to cure disease, and that included giving chemo to people who really shouldn't have gotten it. So I had a very bad experience in medical training, and I contrasted that with my experience with my mother, who was a hospice worker, who took me between the ages of 10 and 12 to a hospice in Los Angeles. And there, I really saw what a good death was. So there are ways to experience good deaths in America, but not within American medicine. And most people die in hospital settings. And this contrasts with where people want to die. They certainly do not want to die in these settings. Cancer is a very prevalent disorder in America, a very frightening disorder. I won't go through all of the statistics here, other than to say that most of us will get cancer at some point in our lifetimes. And psychiatric distress is highly prevalent in individuals that have cancer diagnoses. As much as 50% will have a psychological diagnosis, and it gets worse as one approaches death. All right, so how do we define spiritual distress? So those in the addiction field understand the spiritual domain of illness. It's not understood in all of medicine. Talking about spirituality is usually not something we describe in medicine, but the addiction field for a long time, starting with Alcoholics Anonymous, actually even before that, William James in the early 1800s, the father of American psychology, saw that these Skid Row alcoholics were getting better through these religious conversions. And so there's been the link between religious, spiritual conversion and recovery for hundreds of years. And then Bill Wilson in 1934 gets sober here in Manhattan under the influence of a belladonna alkaloid and has a big mystical experience. And I'll tell you a little bit about the rest of Bill Wilson's story, the part that you probably never heard of, having to do with the LSD psychotherapy in the 50s. But within addiction, we understand spiritual distress, but within people who are dying of cancer is a similar kind of thing in terms of inability to find hope, love, connection, meaning. And so we'll return to this because psilocybin induces and can enhance spiritual states, and spiritual states are linked to health within cancer. So when people get diagnosed with cancer, they have a kind of spectrum of responsivity. Some people cope through denial and are mostly okay. Some people cope through cultivating meaning. They say to them cancer was a kind of gift that helped them realize the things that were most important in life, and they say that it helped reorient their lives. But then there's another group of individuals, maybe about a third, that have this sort of like existential plight or distress, and for them they become depressed and hopeless and demoralized. They have this desire for their death to be hastened. They're more suicidal. They commit suicide more often. So these are the group of patients that we try to help in this study. And when you ask the patients that have advanced cancer what are their biggest needs, they tend to describe them in spiritual themes. They want to make meaning, purpose. They still want to contribute. But unfortunately, we don't meet them in terms of where they want. We doctors, oncologists, other oncologic providers rarely address this domain of illness. But the constructs of a good death have been described for a long time. The Institute of Medicine, the World Health Organization have all sort of come up with these constructs. And pain management, preparing for death, a sense of still contributing to others, a life review. A life review is a really interesting thing that I don't think many people do in terms of stopping to understand sort of the kind of arc of your life and where you've been and where you are now and where you're going. It's, we're so concerned with the present and the future that we often don't take a moment to look back. In the study, one of the things we do to prepare patients for the psilocybin experience is to do an extensive life review, and then within that we do a review of the cancer narrative. The spiritual domain of illness has been defined by several entities, and so what's interesting is that even though the Institute of Medicine, the World Health Organization, the Joint Commission say that spirituality should be part of the cancer assessment and treatment, there really is no great component yet within medicine to address this. And having psychological distress in cancer is associated with a variety of bad outcomes, including poor function, including decreased survival rates of the cancer itself, but this construct of increased hastened desire for death and suicidality are part of it. And existential distress, as it's measured in cancer, similarly is associated with bad outcomes. So hastened desire for death is an interesting construct that occurs in up to a quarter of individuals that have cancer, and cancer individuals are at a higher rate of committing suicide. Let's see, is there a pointer here? A red button? This actually would work. Oh, the red button, okay. The red button? Mm. Anyway, I'll just point with my hand. So, So spiritual well-being is associated with these constructs of helplessness and depression that feed into haste and desire for death. So there's physical domains, people that have more pain are more likely to sort of fall into this. But people that have low sense of spiritual well-being are more hopeless, more depressed, have greater desire for haste and death. In our trial, we tried to affect spiritual well-being, depression, and hopelessness. So even though we didn't measure suicidality, we ended up affecting 3 constructs that could have affected suicidality, and I'll come back to that. So depression, hopelessness, pain, diminished spiritual states are associated with this haste and desire for death, and increasing spiritual well-being is associated with decreased depression, hopelessness, and haste and desire for death. Now, in terms of treating cancer-related psychological distress, there's really no great algorithm. There's not a lot of research done pharmacologically or psychotherapeutically on this patient population. Much of the evidence is borrowed from individuals that have depression and anxiety that don't have cancer. And when you look at the existential domain of illness, there are some psychosocial treatments that have been sort of put together. Sloan Kettering has come up with meaning-centered psychotherapy. So there are a group of existentially, spiritually oriented psychotherapies within psycho-oncology, but there's no pharmacologic agent that can improve these states. And that's part of what we're trying to do in this trial. So let's talk about psilocybin. Psilocybin is basically a fungus. It's found in the psilocybin mushrooms. There's about 180 species of them. They're found throughout the world, but the majority, close to 50%, are in Mexico. And there's a long indigenous use of these substances and a relationship that indigenous cultures have had to these compounds, which is important because indigenous compounds have figured out a way to have a relationship with them that involves things like preparation of the experience, a kind of medicine man integration afterwards, the kinds of things that in an academic setting we've tried to use some of the wisdom in terms of how they've been used indigenously. And in particular, they've been used in the dying process. They help facilitate the dying process. So the use of psychedelic plant-derived compounds has been used for quite a while around this concept of helping people die. But there's a recurrent theme of them being suppressed. Dominant religions have come in and suppressed these kind of satanic cultures, if you will. And within medicine, I'll talk about how there was enormous excitement of psychedelics and history in research here for 30 years, and then it was completely erased from memory, and I wasn't taught about it at all. The beginning of clinical research with psychedelics really happened in 1943 in Switzerland. This is Albert Hofmann. He was a chemist working at Sandoz Pharmaceuticals, and he was working with these ergot derivatives and trying to come up with agents that would help women who are experiencing blood loss during pregnancy because they're vasoconstricting agents. In 1938, he made a bunch of these lysergamides, and for some reason in 1943 comes back to them and gets some LSD compound 25 on his skin, a very small amount, and ends up having the first psychedelic experience. He gets on his bicycle and he's riding home, and he starts to have this sort of strange, weird experience, and the world is shifting around him, and his perceptual field is changing. And he gets home, essentially has like an anxiety attack that he feels he's gone insane. He feels he's possessed by the devil. He thinks his neighbor's a witch. So the first trip, also the first bad trip, right? And so he calls his doctor, and he thinks like, I'm in big trouble, I must be dying. His doctor takes his vitals, he seems totally fine, and says, I don't see anything medically wrong with you. He ends up going to sleep, wakes up the next day, and sort of has the sense of feeling refreshed and optimistic, and he goes back to the laboratory, and things in nature seem more alive, and he gets back, he realizes he's made a really important discovery. He's discovered the most psychoactive molecule that we have, LSD. Sandoz ends up testing it on animals and other employees, and they eventually marketed it in the early 40s, mid-40s as a tool to understand the biological basis of psychosis and as a tool for psychoanalysts to use to augment psychoanalytic psychotherapy. And back then, you could order LSD from Sandoz. Any psychiatrist could. It ended up being used in medical school training and psychiatric training to help psychiatrists and medical students have empathic resonance with the psychotic experience. So it was this sort of like wild time that this new compound was sort of brought into mainstream psychiatry and psychology and medicine, and it started this very long period of it being studied. The psychoanalysts loved this because it gave patients a direct pharmacologic probe into their unconscious, and this was more powerful than even dreams. And analysts describe patients getting better quicker in terms of these agents. It was never formally studied, but it was used as a tool to augment psychotherapy. And that was the psycholytic model. The psychedelic model was really kind of radical within psychiatry. This was the therapeutic application of mystical spiritual states of consciousness And Carl Jung had wanted to introduce therapeutic mysticism within psychiatry, and Freud was very upset. He did not want this new field, psychiatry. He wanted to gain legitimacy. He wanted to be biologically rooted, and being rooted in spirituality and mysticism he thought would be a bad idea. And so he kind of made sure that Carl Jung's ideas did not make it into psychiatry. And so this applying these kind of altered states as a therapy was really a new thing within psychiatry. And it was alcoholism that was the first disease state that it was used. In fact, alcoholism was more studied than any disease state using LSD. There were thousands of patients that received LSD, and close to 1,000 of them were in clinical trials. And we'll talk about that. So this was not a small experiment. There were over 1,000 scientific papers. There were 40,000 research participants. There was a whole new sort of methodology of treatment that was developed. And then, interestingly, it all sort of went away. Alcoholism was the most studied. Terminal cancer was the next. And I'll get into the terminal cancer diagnosis in a minute. But safety was established. They established that if you screen people, you rule out history of psychosis or family history of psychosis. You have 2 therapists. You prepare them carefully for the session. You watch them carefully during the session. And then you integrate afterwards. The rates of adverse events like psychosis and violent behavior were very, very low during this period. And there's this new model of set, setting, and dose that is put together, that one psychological frame of mind before one goes in, the setting in which, the environment in which they're used, and the dose all predict the outcome in terms of it being a kind of therapeutic mystical experience or a kind of bad trip experience. On the left there is our room at NYU, and on the right is the Johns Hopkins room. So to give you a sense, the patients, when they're undergoing the experience, lie supine. They have eye shades on, there's pre-selected music, and you have 2 therapists that sit with them for 8 hours. So it's a very kind of like long day. If you think of like the 45-minute psychotherapy experience, this is a long period of time, and there's a lot that goes on, and we'll describe sort of throughout the day what are the different things. There's a dyad team, a male-female team. There's a fair amount of preparatory psychotherapy where we review the entire narrative of their life. We take a cancer history. We take a family history. And we really get them ready for the experience. We review the range of effects of the drugs. We let them know that these are not going to necessarily be euphoric, ecstatic experiences. They're going to be difficult experiences. They're probably going to have some symbolic encounter with cancer. And we talk to them what happens when they have some scary image or vision or feeling. We encourage them to sort of deal with that in a constructive way, to go towards it and to dive into it, and knowing that we're there to protect them. And then, this is not a kind of pharmacologic effect. The drug does its thing. In many ways, we've conceptualized this as medication-assisted psychotherapy. So it's what comes after that's also really important in terms of interpretation of the highly rich symbolic material. So what happened next in the Prohibition? Well, it was a very interesting time. Psychedelics were part of psychiatry for a long time until Timothy Leary in 1962 got kicked out of Harvard. In 1960, Timothy Leary established the Harvard Psilocybin Project, and there was a lot of interesting work that went on with criminals. But the Harvard administration said, whatever you do, don't use this with undergrads. So what did he do? He ended up using it with undergrads and famous people. And so he violated this kind of rule. Harvard got very nervous. They kicked him out in 1962. And he went on to become the sort of self-appointed, guru of LSD and proselytizer of LSD. And he wanted everyone in America to use it. The U.S. government got very concerned about this, and he kind of taunted Richard Nixon. They went back and forth. Timothy Leary said that Nixon and the government should be concerned about LSD, more concerned than the atomic bomb, that it's going to change culture and all that stuff. So Richard Nixon declared him the most dangerous man in America, and they arrested him for marijuana possession. They put him in jail. He escaped. It was like a whole thing with Timothy Leary. But at the end of it, it led to the Controlled Substance Act. And this is a kind of like fact that not many people know about. In 1970, Nixon declared war on drugs, but essentially declared war on addicts, but it really was a war against LSD and consciousness expansion. But if you feed forward 50 years later, it's essentially minority drug addicts who populate our prisons. And so we've taken a neurologic illness, addiction, and the moralization, the criminalization of it was from this, but it ended up hurting minority drug addicts. So it's the Controlled Substance Act is an interesting, strange, really bad public policy thing. And of course, the most dangerous drugs, alcohol and tobacco, were absented from this. It created this Schedule 1 to 5 category, and all the things in Schedule 1, consider very high addictive liability, no therapeutic utility. All of the psychedelics, marijuana, were placed into this category. And as the U.S. went, so did the rest of the world. We got the UN to adopt the Controlled Substance Act, and then basically the rest of the world, we got them to adopt this policy of the illegality of these agents. So what are these agents? The DSM-4 used to only include 2 types of hallucinogens. Now, it's very hard to describe these agents. The word hallucinogen is actually a very poor descriptor. It kind of like implies that they induce hallucinations and psychotic states, and that really misses the mark by a lot. But the DSM does include the serotonergic hallucinogens. Psilocybin falls in that category. All those agents activate the serotonin 2A receptor. But then there's also the NMDA antagonists like PCP ketamine, MDMA ecstasy, salvia. But we don't talk about alcohol as a hallucinogen or stimulants. And, you know, those agents are very psychotogenic and create hallucinations. The serotonergic hallucinogens create more illusions than hallucinations. So the term hallucinogen is pretty poor. So let's talk about the ethnobotany of psilocybin. And I mentioned it's 180 species. It's throughout the world. It's been used by indigenous cultures. And the terms to describe these agents are kind of weird and strange. My favorite is actually Fantastica. Fantastica, I think, gets it more than any. This is Louis Lewin's term. He was the famous German psychopharmacologist. And back then, the psychopharmacologist self-ingested. So he was self-ingesting along with Arthur Heffter with mescaline, and they were describing the experience. And he wrote a whole book on the subject. Psychotomimetic was the U.S. government's attempt to say this induces psychotic-like states, and even though it produces some aspects phenomenologically of psychosis, that doesn't get it. Psychedelic was Humphrey Osmond's term of mind manifesting, and that's also kind of vague. Hallucinogen is probably the worst one, and theogen is a plant-derived compound that occasions God within. You know, my favorite is actually mystico-mimetic, because even though it seems strange to talk about mystical experiences, within addiction, you know, I was used to doing that. And there's actually psychometric components to mystical experience that psychology has sort of looked at and validated for about 50 years. But if you look at a psychiatric textbook, it will list these experiences as psychotogenic and pathological. But if you really look at the range of experiences, the first interesting thing that happens is you have alterations of sensory experience and kind of an interesting, novel sense of appreciating sound and color and all this kind of thing. There can be a psychodynamic, deeply autobiographical nature to the experience. People can sort of like journey back to parts of their lives when they were younger and have a sense of making connections in these deeply psychodynamic kinds of ways. There's the sort of bad trip part of it that we try to avoid through a lot of preparation, where people can become anxious and have psychotic transient experiences. The archetypal realm is this realm described by Carl Jung, having to do with this highly symbolic landscape and kind of universal images. And then the mystical experience is interesting. And mysticism was described by Walter Stacey, a psychologist, in 1961. And he looked at sort of anthropologic, ethnographic descriptions of these states in different cultures and religions. And there was a kind of commonality that he found to them. And the commonality is as follows. There's a sense of unity in these experiences. There can be a sense of internal unity. People can feel as if they're fusing with some sense of ultimate reality, that they get a sense of, I experienced something that was realer than realer, and I have a sense of like what's going on, who I truly am. There's a sense of external unity, which is my consciousness is part of a greater consciousness. And some of our cancer patients have reported this has helped them deal with the fear of death. Patients can be sort of transported to a different realm of space and time. They can have experience a sense of eternity or infinity. There's this deeply felt positive mood. People can have a sense of universal love and peace and a sense of well-being. People can have the experience of being in touch with elements that are sacred and reverential. William James described this noetic quality, these sort of like deep, powerful insights. And then there's a kind of ineffability, the indescribability of the experience. We have patients that say, well, I experienced infinity. How could I possibly, let you know what that was all about? So these are unusual experiences that religion has described for a long time. So the serotonergic hallucinogens, very interestingly, they activate the serotonin 2A receptor. If you block that receptor, none of these agents have any psychoactivity. So it's very interesting that a sub-receptor of the serotonin system so profoundly alters consciousness. It's also interesting that we make DMT in our pineal glands. So we already make a very potent psychedelic, and we have a neurotransmitter for it. And that is really fascinating in terms of why that's there evolutionarily and what may be the reason. We also have an endogenous cannabinoid system, an endogenous opioid system, and we have these plant-derived compounds in nature that are there. And so kind of putting that all together is interesting to kind of speculate why they're there and why these experiences may have some survival value to our species. In addition to activating the serotonin 2A receptor, activation of that also increases glutamate transmission in the prefrontal cortex. So psilocybin and ketamine actually do similar kinds of things in activating the glutamate system, and the phenomenology of the experiences is similar. These agents also increase dopamine transmission, which, as you know, every drug of abuse does supraphysiologically. But what's interesting is they don't do it enough to activate the nucleus accumbens. The nucleus accumbens doesn't light up in animal and human studies. And unlike other drugs of abuse, this one does not have dependence criteria, and I'll let you know about that in a moment. So psilocybin is a prodrug. It gets default phosphorylated to psilocin. Psilocin is the active psychoactive ingredient. The interesting thing about psilocybin, you can see that by hour 6, the experience is over. So this actually makes it that you can put it in an academic medical setting and be done by the end of the day. LSD is much longer and can last from 8 to 12 hours. There have been 2 neuroimaging groups that have looked at psilocybin, one in Switzerland and one in England. They've come to 2 completely different results. This is PET imaging, and what they found is there was marked prefrontal cortical activation and temporal medial activation and decreased activation of the thalamus. And these are kind of neurocorrelates of the experience, but there's a group in Britain that found just the opposite. They found that this default mode network, which is activated, about 60% of the brain's energy is consumed by this system. And it's a system at rest, and it's a system that when you ask someone to contemplate their life or the future of themselves, it's kind of like metacognitive functions. This area lights up. So some people think it's the biological basis of the I or the self. And interestingly, this group found that psilocybin deactivated the default mode network. The default mode network is hyperactive in depression and addiction. So it led them to think that by deactivating the default mode network, it kind of got people out of these constrained ways of thinking and feeling. And that may have been a basis, one biological mechanism in terms of how they work. So psilocybin is very safe physiologically, and there's no known deaths associated with it. So from the perspective of physiologic safety, it's very safe. The main thing you have to worry about is the psychological toxicity, and this has to do with anxiety and psychotic-like phenomena. But the data of the 40,000 research participants showed that when you carefully screen out, the rates of psychosis and dangerous behavior were very, very low. And I'm going to talk about the 2,000 research participants that have received psilocybin in the last 20 years in the U.S. and in Europe, and let you know about the rates of adverse events there, which this is a kind of older slide. So of the 2,000 people that have received psilocybin in research settings that have been carefully screened for psychosis, there have been 0 serious adverse events. So no prolonged psychosis, no flashbacks, no addiction, no one needing any pharmacologic intervention during the day, no one being psychiatrically hospitalized. So 0 out of 2,100 so far. So the psychological safety, which is the thing that you most worry about with this drug, we've been able to demonstrate that you can safely use it in a research setting. And there's been a recent population-based study that took a look at the use of the serotonergic hallucinogens. This was really interesting, and this was the National Survey of Drug Use and Health data, and it found that every drug of abuse, cocaine, amphetamines, heroin, all of them are associated cross-sectionally with increased rates of suicidal thinking and behavior, but the serotonergic hallucinogens like psilocybin and peyote were associated with lower rates of suicidal thinking and behavior. And so it's possible that these agents may have some anti-suicidal effects, and I'll show you about some of our data and how that may fit. Interestingly, they also did a study down in the Southwest looking at individuals who had been in the criminal justice system there, and there was an association between the use of these agents and decreased recidivism. So Schedule 1 is very addictive, no therapeutic utility. All drugs of abuse, as you know, increase dopamine transmission in the nucleus accumbens, and amphetamine does it the most. And so all drugs of abuse can acutely increase dopamine. And for a drug of abuse to be a drug of abuse, in addition to increasing dopamine transmission and lighting up the nucleus accumbens, animals will self-administer it over and over. You can induce condition-placed preference. And epidemiologically, you have use disorders. The serotonergic hallucinogens don't fall into any of those categories. They don't lead to self-administration. You don't get condition-placed preference. The nucleus accumbens doesn't light up. And epidemiologically, you really don't have this finding of LSD addiction. These drugs can be misused, they can be abused, they can be dangerous, but they do not cause addictive syndromes in the classic kind of way. There's also a lot of tolerance. So if you take LSD for several days, by day 2 you have 50% decrement in subjective effect, and by day 3 you almost have no effect. So a drug that is so unpredictable, potentially so adverse, and has such great tolerance really doesn't fit the bill. And we know that the most addictive drug is nicotine, and the psychedelics are towards the bottom. There have been tens of millions of Americans that have used these agents. This is an interesting slide. It looks at, on the x-axis, active dose versus lethal dose, and then on the y-axis, addictive potential. And you can see the most damaging drugs in society, as we know, are things like alcohol, tobacco, the opiates, obviously. And in this construction here, the serotonergic hallucinogens were sort of in that sort of low left quadrant. So if we were going to make drug policy and to schedule things based on relative harm, addictive liability, it potentially would look much different than it is now. And again, the most damaging drugs, are not even scheduled. So Bill Wilson did get sober from a mystical experience with the belladonna alkaloid. He, at Towns Hospital in 1934, had the experience of white light penetrating through his hospital room. He experienced that as God. He had a vision of alcoholics forming a chain, and that was his vision of the kind of mutual self-help of AA. And then in the 50s, he underwent LSD psychotherapy at UCLA, and again had mystical experiences, and came back to the board of AA and wanted to introduce LSD to the board of AA, and they said no. But you would never know this story knowing AA today. AA is sort of like in some ways morphed into a highly kind of conservative place where you can walk into some meeting and say you're on Prozac and you can be told you're still an addict, or a lot of places you go and you're on methadone. No. And interesting, Bill Wilson, he was a big fan of Vincent Dole. They were friends. He wanted to introduce methadone. He wanted to introduce LSD into AA. He was on antidepressants. So it's interesting to kind of like think of the story of how Bill Wilson got sober through a psychedelic experience. There was a recent meta-analysis in 2012 that looked at the controlled trials of alcoholism and found that single dose of LSD increased the quit rate or the decreased alcohol rate double compared to the placebo, single dosing placebo, and the effect lasted about 6 months and disappeared by 12 months. And Michael Bogenschutz is a new colleague at NYU. He recently did a trial in New Mexico before he came to us of psilocybin-assisted motivational interviewing and found pre-post, which isn't surprising because we know motivational interviewing by itself will decrease drinking, but found that psilocybin-assisted MI decreased heavy drinking. And interestingly, he and I then designed a controlled trial, which we're doing at NYU, of comparing psilocybin to control for alcoholics, and that's going to happen over the next several years. There was also a trial at Hopkins using psilocybin to treat tobacco addiction. This was also open label, psilocybin-assisted CBT, and this was also highly successful. At 6 months, 12 out of 15 participants were tobacco-free. It's only a small sample, and now they're doing a controlled trial, comparative efficacy trial of psilocybin versus nicotine replacement. And the University of Alabama is doing a trial of psilocybin-assisted psychotherapy for addiction. So the most promising indication for these agents was addiction, and they're sort of making their way back. So let's talk about the sort of historical data, and then I'll get into the results of our trial. So when LSD was first available, the first psychiatrist and medical doctor to study the use of LSD to treat cancer-related distress was Eric Kass. Now, Eric Kass was an internist and a psychiatrist at the University of Chicago. And in the 50s, without knowing anything about LSD, he ordered some up from Sandoz Pharmaceuticals. He was interested in terminal cancer and pain, and he thought maybe this could be a novel pain treatment. So he ordered up some LSD, and he did this hundreds of times. I mean, it's sort of frightening to think of what he did, but he did it. So he'd come to the patient's room in the morning, and he would say, "Hey, I'm Dr. Kass." And his patients really loved him. He was a very sort of, empathic, great doctor. And he would have them stick out their tongue, and he'd put a drop or two of LSD, 100 micrograms on their tongue. And he would say, "Okay, have a great day. I'll see you at the end of the day." Like that's it. No preparation, no nothing. I mean, that's like what you would never want to do. But he did it. He did like 300 times, and it was pretty amazing what he found. He actually did a comparative efficacy trial of LSD versus opiates, and found that in the short term they both had anti-nociceptive effects, but the LSD group persisted at several weeks. So he started to notice, wow, this could have an anti-pain effect. But what he noticed, in addition, the patients felt calmer after the experience. They reported decreased fear of death, and he realized, oh, there's something more going on. And open label gave it to several hundred patients and continued to find the sort of decreased fear of death, decreased depression. But without a controlled trial, we can't attribute the psilocybin to this. So there was a group at Spring Grove, Maryland, led by Stan Groff. Has anyone heard of Stan Groff, by the way? He's like the most famous psychiatrist that no one's heard about within psychiatry. He was like the LSD pioneer. He was from Czechoslovakia. He basically invented LSD-assisted psychotherapy. He came up with the whole model of preparation, patient lying supine, music pre-selected, artwork, and all of this kind of indigenous use within an academic center. He was a Johns Hopkins professor, and he was the head of the Spring Grove Research Group. And this was a group of leading academic psychiatrists and oncologists that came together to study psychedelics. And they were studying terminal cancer and addiction. And they were going to do an open-label trial followed by a control trial. So they did an open-label trial using LSD, but also DPT in 60 terminal cancer patients. These are essentially the exact inclusion and exclusion criteria that we use, including, in particular, excluding people with major psychiatric illness. Preparation, dosing, integration. What they found pre-post was decreased depression, decreased anxiety, and decreased fear of death. So they were very excited by this, and they were about to do a controlled trial. But then that was exactly when the Controlled Substance Act hit. And so Spring Grove was dissolved, and all of the most promising psychedelic research of the day essentially ended. And he was sort of banished from academic psychiatry. He went to Esalen, and he ended up inventing holotropic breath work. And, in the kind of counterculture world, he's well known. Similar to how Carl Jung is well known in that world, but within academic psychiatry, you really don't know much about these guys. So in the modern era, if you're going to do a controlled trial with these agents, you'd want to have these kinds of essentials, including severity measures, informed consent, a placebo group, random assignment. You want to standardize the psychotherapy because that is a component of treatment. You probably want to manualize it and do fidelity monitoring. You want objective blind raters. So essentially, UCLA, Johns Hopkins, and NYU have all done a trial using this. This is Roland Griffiths at Johns Hopkins. They've really pioneered psilocybin administration. They've done it in normal individuals. They've done it to enhance meditation. They've done it in tobacco addicts. They did this cancer trial. So they really have been pioneers in this. And what they found was really interesting. In giving it to normal volunteers, there's a mystical state of consciousness questionnaire that we give our participants. And they were able to find, their control here was Ritalin, that psilocybin indeed induces mystical experiences compared to placebo. But more than that, and this was the sort of dark side of it, they used high dose. They showed that even in careful preparation and good guides, you can still have transient anxiety and psychotic-like thinking. And this, to me, is the most concerning part of this. And this is in particular why you do not want to give this to patients with psychosis-related conditions. He found in this study that the patients, 3 out of 4, said this was the singular top 5 most meaningful experience of their lives. They said up there with having kids. So they experienced these highly memorable, meaningful, spiritual, profound experiences that led to sustained changes in cognition, affect, altruism, behavioral changes that were attributed to the psilocybin. So in terms of the current studies, I want to get into our data. But this trial was the first trial. This was Charlie Grobe at UCLA, and he was able to get a group of patients that had terminal cancer who were dying. He recruited 12 people at UCLA. His dose was 0.2 milligrams per kilogram. Ours is 0.3. Hopkins is 0.43. It turns out 0.2 is too low. Hopkins did a dose response study, and it looks like that 0.3 is sort of the kind of sweet spot in terms of creating mystical states but having lower rates of adverse psychological effects. Because as you go from 0.3 to 0.4, you start to have more of that anxiety and paranoid-like stuff. But this dose is too low. People have effects, but Charlie found that it probably wasn't therapeutic enough, and his sample was low. But he really was a pioneer, and Charlie is the one that got me involved in this. I had been a medical student at UCLA. But interestingly, even though this was done at my favorite hospital, which was kind of the Bellevue of the UCLA network, Harbor, I never heard about him. So he's the head of the child division and kind of doing it there. And he published in the Archives of General Psychiatry. His exclusion and exclusion criteria are exactly what we have done. So the same sort of stuff. Again, important to screen out unstable medical illness and psychiatric illness. Preparatory psychotherapy, the dosing of the 8 hours, the post-integrative psychotherapy, And so this was their Clinical Translational Science Institute at Harbor. So this is probably not the room that you wanted. It's like a very medical-looking room. But to deal with that, they, threw up some Los Angeles. I thought we could do better than that, which we did. But it was better than all the hospital-looking stuff. Anyway, what he found is that they were able to recruit people. There were no SAEs, and even though the study was underpowered, they found that there were mystical experiences of psilocybin versus placebo. What they found is, if you look here, this is the psilocybin group that comes down here, and that's the placebo. So you can see there is a greater decrease in terms of the psilocybin group. This is a stave. This is an anxiety measure. But they were not statistically significant, so the differences weren't great enough. And I'll show you our data where the effects are more pronounced because we have a bigger dose and a bigger N. But they did find that after, this was a crossover trial, so they got psilocybin first and then niacin first, and they crossed over at 2 weeks. Our crossover was longer at 7 weeks. But they did find enduring differences pre-post in terms of trait anxiety, but who knows if that was the psilocybin, the psychotherapy, or the placebo. And all of the findings were like this. They found a trend towards decreased depression, but it wasn't statistically significant, but at 6 months, pre-post it was. So this was an interesting trial, but it didn't really definitively establish the utility of psilocybin. Hopkins just completed their trial, 44 patients, psilocybin-assisted psychotherapy, cancer patients with anxiety, depression. They found essentially what we found. There was also an LSD trial that was 12 participants, and this is the first LSD trial that's been done in 40 years, and this was also a controlled trial, and they showed improvements in anxiety of the LSD group versus placebo in the short term. So this is our research group. We started this group in 2006, and it took a while to get approval to do this trial. There was a big regulatory burden. This was a collaboration between the NYU School of Medicine and the NYU College of Dentistry. You probably noticed that I have those dental titles on but it's really not that impressive. I have zero dental training, know nothing about dentistry. We wanted to do this trial at Bellevue at our Clinical Translational Science Institute, but Bellevue was hesitant to do a trial giving a psychedelic to dying minority individuals. They thought that would look bad in terms of the optics. And my response to that, I was upset that because they're a minority and they would potentially get something that would be helpful to them. So in the phase 3 trial, we would want to come back to Bellevue, but we literally had an approved trial by the government and our IRB, but we had no place to do it. So one day, the head nurse of the CTSI said, well, why don't we go to the dental school and you can check it out there. And at first I thought, why would we go to I didn't even know NYU had a dental school. But it turns out they're the only dental college that also does non-dental studies, and we went over there. And we had always thought this trial should be done like a spa-like setting. And it turns out that they had this Bluestone Clinical Research Center that looked very much like a spa. It was a beautiful sort of place. And they gave us a room there. And we teamed up with dentists. The only psychedelic study ever done in dentistry was this one. So that's the thing I'm most proud of. And then they made me a faculty member, and I teach them about addiction because there is an interface between addiction and the mouth. But that's a different topic. So we recruited 29 individuals, 18 to 76. This was 9-month duration. It was double-blind placebo control. There was a crossover at 7 weeks, and it was just single dose of psilocybin versus single dose of placebo in a platform of psychotherapy that had cognitive behavioral components, psychoanalytic, existentially oriented components. We included, initially this was going to be for patients with terminal cancer, but we went over to the cancer center and we soon found out that you did not have to have terminal illness or cancer to be distressed. In fact, we found people who were in remission who thought that the boogeyman was going to come back and that it was going to get them, and they had enormous distress. So we realized, okay, this is not just for people who are dying, it can be anyone who's severely affected adversely by cancer. Similar medical exclusion criteria to the historical trials, the UCLA trial, same thing psychiatrically. Our primary outcome was anxiety, but we also looked at depression, pain, spiritual measures, quality of life, and measures looking at acceptance of disease progression, death anxiety kind of thing. We did this life narrative, we did a cancer narrative, and then we really prepared them for the session going over all the safety parameters. We let them know that that I had expertise in dealing with psychiatric emergencies, we would bring a benzodiazepine, and we had an atypical antipsychotic if we needed to. The atypical antipsychotics are 5-HT2A antagonists, so we would let them know we have a pharmacologic antagonist if you're having a difficult experience. Here are the meds, and we're putting them in a drawer next to you. We really wanted them to know that they were going to be taken care of during the experience. And the psychotherapy here is really odd. You end up doing things that you're trained never to do in psychotherapy. Have physical contact with patients, reassure them, hug them, have them snot on you. When they're really, so you really have to be well trained as a psychotherapist, in particular to understand boundaries and what can go wrong. And that's why it's important to have two therapists there, male and female in particular, because these are very highly unusual, vulnerable states of mind that the patients sort of are transported to, and it's really important the rapport between the therapist and the patient. So this was a huge regulatory burden. In fact, my research mentor, John Rosen, when I first came to him with this, he was like, forget about it. You should, you're crazy. You should never do it. It will ruin your career. You'll never get approval. It'll take forever. And so I thought about, well, I may as well just try, So I applied to the FDA, and actually dealing with the U.S. government was the easiest part of this. And I thought that would be the hardest part. So I applied to the FDA to get an investigation new drug license, and they have a month to say yes or no, we need more information. But I wasn't the first person that had done it. The seal of doing psychedelic research was broken in the early 90s. So it was made taboo, but then in the early 90s, Rick Strausman at the University of Mexico got approval to give IV DMT to normal volunteers. Now, IV DMT is very, very potent, and the participants there had like alien abduction experiences, and so it was a kind of interesting trial. He found out that IV DMT really can get you way out there. So you have to shut that down, and then Charlie Grove at UCLA got approval to do his study, Roland Griffiths at Johns Hopkins, and Francisco Moreno at University of Arizona. So when I applied to FDA, there were all these INDs. FDA had already made the decision that if it's an academic medical center and they're scientists and good protocols, they're going to allow this to continue, which is fascinating because whereas you can get permission to do psychedelic research, it was almost impossible to get permission to do cannabis therapeutic research because that was a different process. It went through NIDA and the DEA and et cetera. So eventually got an IND from the FDA. Then our oncology review board had to review it, and it didn't look good. That board was highly skeptical, and it looked like that wasn't going to work out, but we made it through that. Our IRB, was very open-minded, and it has been very open-minded. We've done I'll tell you a little bit about our psilocybin-alcoholism trial and our psilocybin religious professional trial, and our IRB really had a difficult time with the latter one in terms of why we would do that. It took a while to get a Schedule I license. You have to get a Schedule I license through the Department of Health in New York, and then the federal DEA comes and inspects. And so we eventually did get our Schedule I license, and this is what our room looks like at Bluestone. It's a very nice room. Okay, so here are our results. So we screened 108 individuals. We enrolled 42. We randomized 31. And they were either randomly assigned to the niacin first group, the placebo, or the psilocybin first group. And some of the people died because obviously they had cancer. And so this is about the typical size of a phase 2 trial. It's not a huge trial. It's not a definitive trial. One of the limitations is that it's a small sample size. And you can see the sample size is biased. This is not the Bellevue population. This is the Clinical Cancer Center population. That's where we were allowed to recruit from. And so you can see it was, mostly women more than men. The typical patient was a Caucasian woman in her mid-50s that had metastatic gynecologic cancer. And you can see 90% Caucasian. About half people were religiously affiliated, about half weren't. In terms of the site of cancer, the gynecologic was most common. And, about 70%, 60% of our participants had advanced cancer. So this really started out as a trial for advanced terminal cancer and ended up, the majority of patients did have that very sort of severe variant of the illness. Okay, so we did find adverse events. From a medical perspective, psilocybin is a sympathomimetic, so it does increase blood pressure and pulse in a way that's non-clinically significant. It can induce headaches and migraines. It can induce nausea. Psychiatrically, again, this is the kind of dark side of these agents. With good preparation, we still have people reporting anxiety that was upsetting enough that we rated as an AE. And some people did report paranoid-like feelings or thought disorder. These were transient and they were all managed, but it's important to know that they are there and need to be managed. But there were no serious adverse events, and that was in line with the 2000 sample I mentioned. So these were the time points. The important thing scientifically is that they're crossed over at 7 weeks. So between baseline and 7 weeks, we were able to compare the two groups. That's really the most important part of the study, because after the crossover, it gets hard to attribute what to what, even though I will make the argument that our therapeutic benefit of psilocybin lasted probably around 8 months, and I'll get into that. But the really scientifically most important thing is pre-crossover. And what you have here, so you can see these are our main measures here. The HADS is a measure of anxiety and depression, and it has an anxiety subscale, a depression subscale. The BDI is a depression inventory. The STAY is an anxiety inventory that measures state anxiety, which is sort of acute, or one's current state of anxiety, and TRAIT, which is a kind of more temperamental long-term thing. And you can see these are the two groups. So just to give you a sense, the HADS group, they both have enough, they both have some sort of equal distress at baseline. This is 1 day before dosing, and you can see this is probably like placebo effect. Being in a study, people start to feel better, that they're going to get help. And so, but 1 day after dosing, the psilocybin group, they go from like 13 down to 5, and the placebo group, goes down a little bit, but really kind of like bumps back to its baseline, whereas the psilocybin group continues to be low up until 6 weeks post-dosing. And these are the effect sizes, which measures the magnitude of the difference between the two groups. And these are enormous effect sizes. For a drug to become an FDA-approved medicine, it only needs an effect size of about 0.3. So these are considered enormous effect size, large magnitude effects, which really fit with our clinical observation. Patients would tell us, right after the experience, I feel, so much better. I don't have death anxiety anymore. And they would report the next day feeling better, and then weeks later and months later. So we were seeing these very kind of dramatic changes in depression and anxiety and orientation towards death. And so the data really kind of confirmed what we were seeing clinically. And to kind of like show you what it looks like graphically, so this is the psilocybin group. So this is when they get dosed. So you can see this big steep drop-off in distress that basically stays there up until the 6-week mark. And the control group, again, there's like a placebo effect, but then the distress bounces up. And all of our between-group measures look like this. They're all the same. Psilocybin group versus a placebo, all of them large effect sizes. But I think the most interesting thing is this. So this is now going out to 26 weeks. So you can see someone gets psilocybin here, and 8 months later, you can see essentially their distress stayed down the entire time. Same thing here. So when they get psilocybin, the effect appears to last for many, many months. Again, there's a crossover that occurs right here. So beyond this point, you can't definitively say it's the psilocybin. But what's also interesting is when the control group gets the psilocybin, from here to here, from there to there, you start seeing within group differences. So the control group does improve pre-post when they get psilocybin, and you can see the groups statistically kind of end up towards the same. The psilocybin first group did appear, to have greater benefit, but these are sort of like interesting long-term data that suggests that the single dose effect may be as long as 8 months, and this is what they all look like. In addition to that, we found that the psilocybin group, this is the mystical scale that I measured. The blue is psilocybin. So compared to placebo, patients on psilocybin are having mystical experiences. This sort of gets at therapeutic mechanism. The x-axis here is the intensity of the mystical experience 7 hours after getting a dose, and this is a clinical drop. This is like a reduction in distress, and you can see that there's a correlation. Those that had higher mystical experiences are having greater reductions in clinical distress. And so there may be a kind of potential psychological mechanisms between the intensity of the mystical experience and clinical benefit, but what that actually means and what's the driver is hard to know. We did do a qualitative trial looking at it, so we are trying to unpack the dimensions of the mystical experience and to see, how to understand. Is it a sense of external unity, that your consciousness is part of a greater consciousness that helps, or Or is this maybe have nothing to do with it and it's really a biological thing that's happening and this is not the main driver of therapeutic effect? But what's interesting is that in the tobacco trial that I mentioned, there too they found a correlation between intensity of mystical experience and therapeutic outcome. In the alcoholism trial, same thing. So this had been reported in the earlier LSD trials that there were these anecdotal reports, the intensity of the mystical experience seemed to be correlated with outcome. And in the modern era now, we're showing, that does seem to be the case. So there's something going on there. Our secondary outcome measures, we looked at attitudes towards disease, and we found an anti-death anxiety effect. This was a death anxiety scale. And this was short-term, 2 weeks. But at 2 weeks, there was a greater reduction in death anxiety in the psilocybin group versus the placebo. There was a greater, these are change scores. So this changed like 16 got better by 16. This only got better by 4.5. So there was decreased death anxiety, decreased demoralization, decreased hopelessness. There was improved quality of life from a physical and psychological perspective. And we were able to find that there was an increase in spiritual well-being, but also an increase in this construct of intrinsic spirituality, which has to do with the parts of religion that have to do with the transcendent, meaning-making, a sense of personal well-being. The faith part has to do with the behavioral practices of religion. And this goes along with data that shows that if you're just religious and spiritual and it's not connected to a connection with God or community, it's just, going to, temple on the high holidays or church on the big holidays, and you feel like you did good and God should reward you, and then you get sick, those people can be very mad. I did everything I was asked to do, but now I'm sick. Now I'm angry. So the kind of like more intrinsic aspects of religion are related to decreased distress. And I showed you this earlier. So we were able to increase spiritual well-being, decrease hopelessness, decrease depression. So we affected 3 constructs that affect desire for haste and death. We didn't measure this even though there's a scale, and we didn't take people who were suicidal. But it is possible that psilocybin also had anti-suicidal properties, and that would fit with the data I mentioned earlier on the population level, which would be very interesting because, we don't really have things that work right away in psychiatry except ketamine. And there's also data showing ketamine has anti-suicidal effects, but to have something that worked right away for suicidality would clinically be important. We also found enduring positive changes in attitudes, mood, altruism, spirituality. These are the sort of persisting effect questionnaire. We asked people to report on these different domains attributed to the experience they thought they got psilocybin. But we asked them how personally meaningful the experience was, and this is similar to the Hopkins data. You can see that the psilocybin group at 2 weeks, about half of them said this was the singular or top 5 most meaningful experience of their lives. And about 8 months later, we asked both groups to reflect back on what they thought was the psilocybin experience. And there, it goes up even more. 68% said it was a singular top 5 most meaningful experience of their lives. The spiritual significance, similar kind of stuff. So these are highly salient, memorable experiences that people rate as having a high impact, an increase in personal well-being. So to summarize, and then I can stop and take questions, we were able to establish in this small phase 2 trial that we could safely administer psilocybin to individuals without any enduring harm to them. We were able to show that psilocybin was an acute-acting anxiolytic and antidepressant in a population that mostly had adjustment disorder. These were people that had moderate distress. And taking people that are moderately distressed and showing statistically significant effects are harder. If you have a group that's really, really sick, it's easier to see an effect. So we had a group of people that were distressed but moderately distressed, and we showed that we were able to improve benefit there. But in addition to the acute-acting rapid effects, we were able to show that the effects were sustained, at least up to 6 weeks, maybe even 8 months. So there is nothing in psychiatry that you give to a patient that works right away that works for months. So this is a kind of new finding in psychiatry and a new model, but it's a kind of new model that's an old model because in the LSD research there was a lot of this by anecdote. It seemed to work a long time, but no one ever in a controlled trial was able to show that. We found that psilocybin-induced mystical experiences, the mystical experience was correlated with clinical outcome. These were highly spiritually significant, meaningful experiences. And there were positive changes in cognition, mood, behavior, increases in altruism, increased quality of life, decreased death anxiety, decreased depression, hopelessness, demoralization. So what are the next steps? We have written up a manuscript, and Johns Hopkins has as well. Johns Hopkins found essentially the same kinds of findings. They had a higher dose. Their effect size was lower because their active control was low-dose psilocybin. So they tried to get, they tried to have good blinding integrity, which was better than ours. Everyone knew when they got in our trial psilocybin versus niacin. So you could say that creates a kind of bias. It decreases internal validity. Hopkins had greater obscuring, but it turns out low-dose psilocybin has some therapeutic valence to it. So the magnitude between the psilocybin and the control was smaller there. So the next step is to do a phase 3 trial, and we're now seeking funding for this and speaking to the FDA. If the FDA allows a phase 3 trial to go forward, that would be 200 to 300 participants. That would put psilocybin potentially on track to be rescheduled and to become a prescribable medication, which would be very interesting. It probably would never be something that you go to CVS and get and take home. It'd probably be highly regulated only in certain clinics, only by certain practitioners, which is really the right way to do it. Psychedelics within medicine can be done safely and can have therapeutic effects, but they have to be done very, very carefully. The problem with psychedelics is, how they're mostly used in America, which is high school students and college students without any preparation, use it in party settings and get into trouble, and really bad things happen. The New Yorker in February, Michael Pollan did a piece, I think it was entitled something like Medicine Psychedelic Revolution, and he, kind of like let the, everyone know that this stuff has sort of started again. And after that article, I was contacted by at least a dozen major medical schools and entities that were interested in doing this, from Stanford to UCSF, Yale, Ohio State University, and even in the South, Alabama, Louisiana State University, UT Southwestern, Emory. So it was very interesting that, and sometimes it was like the chair of a department, which I found very interesting, but often it was the medical student or resident thinking, this is really interesting, how can I get someone at my institution involved? So I think the very interesting thing is that psychedelic research came back, but it came back within the heart of academic psychiatry, and all of the people that have done this research have had senior leadership positions in their hospitals. So it's interesting to consider all that and to consider the future, both the potential therapeutic effects of psilocybin, but also the potential harms associated with it. And every drug of abuse we should look at in that way, where it's undergoing now with marijuana. Is it really the worst thing ever, or is it the greatest thing ever? And it's neither. There's relative harm and potentially relative therapeutic utility, and we really need to kind of understand that and look at the data. So thank you for your time, and I'll take questions.